Okay, sorry for that.
Okay.
Welcome everyone. Going to start again. Phaco and uveitis. There are certain problems that you anticipate when you're confronted with a patient of uveitis. The most important of which is reactivation of the inflammation. Synekia, small pupil, decision whether to implant or not, and what type of lens material if you're going to implant. Preoperative management is most importantly, you need to control the intraocular pressure at least 3 to 6 months before the cataract surgery. And this is universally agreed upon. You need to sit with the patient or the parents of the patient and talk about the benefits and risks of doing cataract surgery in a uveitic patient, because you can clear up the inflammation. The other thing is you need to talk about the lens implantation, whether to implant or not, and the possibility of if you implant and things doesn't go well, you have to go in again and remove the implanted lens. You need to increase the dose of the immunosuppression, the patient on about 10 milligrams of steroids before, 1 week before and 1 week after the surgery. I usually give intravenous fast-acting steroids, prednisolone or dexamethasone, intraoperatively as well. During surgery, you need to do synechiolisis. You need to dilate small pupils, whether by stretching the pupil using iris retractors. It's not a very good method because it entails a lot of trauma to the iris. Better do iris hooks or Malugin ring. This is the one we usually use. Sphincterotomies, you can revert to that if the pupil is sclerosed and difficult and not malleable. If there is a pupillary membrane, you need to peel that first and don't try to forcibly stretch the pupil, otherwise you get tears at unexpected points. Last point is that you need to do a very good cortical cleanup. You cannot leave any lens matter behind in this potentially inflamed eye. The question you need to ask yourself whether this patient is a good candidate for intraocular lens implantation. There are types of uveitis that has a good reputation with intraocular lens implantation, like Fuchs heterochromic uveitis and Vasculitis, Behçet's disease, whereas granulomatous uveitis such as sarcoidosis and VKH doesn't have a very good outcome usually. As a general rule, if you have a lot of flare in the anterior chamber, chronic flare, this means a chronic break of the blood-aqueous barrier, and these patients are poor candidates for intraocular lens implantation. In any case, you need to have a special care with patients with one eye, especially if the other eye has been lost from previous cataract surgery. The lens material we used to use heparin coated, but it's not available anymore. However, hydrophilic and hydrophobic intraocular lens are very well tolerated by uveitic patients. However, the first generation silicone lenses, mostly not available now, and PMMA lenses still present, are not very well tolerated. You need, when you implant the intraocular lens, you have to put it in the bag. You cannot place the intraocular lens outside the bag. Avoid capture of the optic by either the lens capsule or the iris. Avoid large rhexis. Avoid iris mounted or anterior chamber IOL. You cannot touch the IOL with the uvea in any case. This is what you're trying to avoid. This is the first video how you do their synechiolisis using a viscoelastic cannula. This is another case. After doing the synechiolisis, you dilate the pupil with iris hooks or Malugin ring, and then do the rhexis. Most of these patients have a very soft cataract, and it's very easy to remove once you've done the proper synechiolisis and dilating the pupil. Once you've removed it, you need to put the lens inside the bag. Here is a pupillary membrane. Now you peel it before you put your iris hooks. You should be very patient, and you can use a bimanual technique if the iris is too floppy. Here is another child who, once I've opened the capsule, a lot of fluid came out. This is why I use an insulin needle beforehand, so that I can aspirate whatever causing this positive pressure. And then you don't do a very large rhexis in these children, because it tends to run out the capsule. And hydrodissection or visco dissection, very soft, so you can remove it. After I removed it, I found out that there is a dense vitreous condensation just behind the posterior capsule. So I did a very small posterior rhexis, and then you need to make it small in these cases, because you're going to implant your IOL in the bag. You cannot put it in the sulcus. Once you've done that, you go with the vitractor, remove as much as you can from the vitreous condensation. Once it's pretty clear, you put the IOL, try to put it first in the anterior chamber, and then very carefully put it between the two leaves of the capsule, the leading haptic. Once you've got the leading haptic right, the trailing haptic is much easier, because it follows the trailing haptic. This is a more complicated case. This is a child with juvenile idiopathic arthritis who had a band-shaped keratopathy and raised intraocular pressure. I did first PTK, and then tried to go into the anterior chamber, but he had almost 360 degrees peripheral anterior synechia, not allowing me to go in. So I chose a point where there is no synechia. I went in, did a peripheral anterior synechiolisis by sweeping the viscoelastic cannula. Once I've done that, I started to do, I entered properly and did a posterior synechiolisis again with the viscoelastic cannula. Put some iris hooks, did the usual phaco, put the IOL in the bag again. And then in children, sometimes you need to put a suture. Usually you have to put a suture because the cornea is too pliable. In this next case, this is a child who had a parasitic granuloma in the inferior angle, and it was active. And one of the methods of stopping the activity is removing the fleshy part of the granuloma. This is what I'm doing. I'm trying first to dissect it from the cornea, and then dissect it from the iris. Doing that with the anterior chamber forceps, microforceps, and then did the rhexis. The capsule here, because of the pigments, it's behaving a little bit abnormally. However, it went fine. The cataract itself is pretty soft, so it's easy to remove. Once I've cleaned everything, put the IOL, and then I attend to the granuloma, try to remove the rest by manual technique using a scissor and the microforceps. Remove as much as I can. Part of it here was not removable. It's very, very tightly adherent to the cornea and to the iris. So I just left it behind. And this child did very well after that. The eye went completely white after raging inflammation before surgery. This is a child who came with a very angry eye after having a cataract surgery elsewhere and putting the three-piece IOL in the sulcus. So the only way to save this eye is to go in and remove the lens. And it's sometimes very difficult because you have an encapsulated lens. I'm trying to cut the capsule and then remove as much as possible from the capsule. And then to try to save the wound from being a large wound, you cut the lens in situ. You can see the red reflex is getting a little bit better. You do the peripheral anterior synechia. Try to remove as much as you can. However, it tends to recur after surgery. And cut the lens. And then remove it from the anterior chamber. And once you've done that, as you can see, the red reflex is pretty nice. And this is very characteristic in juvenile geopathic arthritis. You have a very angry anterior chamber and very quiet posterior chamber. And this is another child who had the same thing, removal of an intraocular lens and fitted with glasses, which is happy, bifocal glasses. Thank you. Dr. Trace, are you still with me?
Yes. We actually don't have any questions, but I can start triggering a discussion here. So I wanted to ask you if you had any particular regimen, if you had a patient with infectious uveitis such as viral iridocyclitis that developed a cataract or toxoplasma, would you consider using the antimicrobials for these patients?
Oh, definitely. I would give oral ganciclovir beforehand, or acyclovir beforehand, and we continue that for few weeks actually.
And toxoplasma likewise, I believe. Would you do?
The presence of, I never had a cataract and toxoplasma at the same time, but I mean, I had toxoplasma. I had to treat with antimicrobial, of course.
Yeah, because I do this for the reason that using anti-toxoplasma medications before cataract surgery in these patients who have been quiescent, who have had their toxoplasma uveitis completely treated, would decrease the risk of recurrence after surgery by 60%. So this is why I brought up the question.
Okay.
I had another question about, would you routinely have an anterior vitrectomy for patients that you in uveitis who have cataract?
Oh, definitely not.
Okay.
I wouldn't, unless there is a dense vitritis, and if there is a dense vitritis, then I would refer to the vitreoretinal guy. He would do
You would not do an anterior vitrectomy.
As you've seen in the case I've presented, I was confronted with the anterior vitreous condensation that I had to go through a posterior rex and get it. It's very crucial to put the lens in the bag.
Yes.
So this might compromise if you go and do a vitrectomy. You might compromise that. In children, you can, after implanting the lens, you can go behind the through pars plana and do an anterior vitrectomy or do a posterior rex as I have done.
Okay.
Because they will have a classified posterior capsule anyway in either case. So you might as well do vitrectomy.
So we had a question from the audience, and they were asking how much benefit would you gain by having a peripheral anterior synechia lysis?
Very little, actually. You have to try anyway. They usually recur very quickly, but you have to try. Sometimes there is you free a little bit of an angle that is enough to control the pressure of this child.
Okay, we have a few other questions. They were asking, someone was asking, for how long will you use systemic steroids post-operatively and at what dose?
Well, I actually use the topical steroids a little bit frequent the first week, about every 2 hours, and increase and put the ointment as well at night, and then go the normal routine 6 times per day for a week, 4 times per day for a week, twice for a week, and then that's it. However, I'm covering the period, the first week before and after, with the 10 milligrams of steroid above the systemic therapy that the patient is already on.
Okay.
In children, I tend to be a little bit more aggressive. I give every hour for the first few days.
Okay, someone was saying, do you have any experience with injecting diluted triamcinolone acetonite and leaving it in the anterior chamber at the end of surgery? injecting Kinacort?
I think it's not a very good idea. I mean, injecting trimetrilone inside the eye in a uveitic patient in general is not a good idea. The one available here locally is preserved with alcohol as the preservative. So this would be very irritant in the case of uveitis. A normal eye might tolerate it, but an eye with uveitis is not very well tolerated. In the anterior chamber, there's no point at all. Yeah, sometimes doctors would inject in the posterior, in the vitreous, for the sake of control of inflammation. And I'm against that. If you're going to inject steroids, just go with Ozurdex. This would be better.
Someone was asking you if you would inject posterior subtenon a week before the surgery.
Again, no. I wouldn't do anything more than this. The extra thing that I use that's not universally agreed upon is that I give intravenous steroid during the surgery. But there's no evidence that this improves things. Yeah. It's very important to keep the patient controlled for at least 3 to 6 months before the surgery. This is the key in this. I never had a problem with a uveitis patient post-operative.
If you had a patient, this is a question from me. If you had a patient who has high intraocular pressure and you can control it medically, and the patient also has a cataract, would you prefer to go for a combined procedure, or would you just first have the glaucoma surgery, then later on go for the cataract surgery? How would you go?
I would do both surgeries at the same time.
You do both surgeries.
Yeah, it's not proven that this would increase the inflammation. If you do, it's very simple.
But would it increase the failure of the glaucoma surgery?
It would, but not in every patient. In children, for instance, you have risk factors. For instance, uveitis is a risk factor. If previous treatment given dark complexion is a risk factor. So if you have a lot of risk factors, especially if the patient is a child, then you can go with a combined valve and a cataract surgery.
Okay. I wanted to discuss something you mentioned. You mentioned that in patients who have VKH and have sarcoidosis, that they tend to have a worse prognosis
not always.
Yes,
not always.
That's the point, because if you have a patient who is VKH and it's been well controlled from the start, I think at the point the patient, it would depend on how long he was well controlled before the surgery, rather than it just being a VKH with a bad prognosis, I guess.
There are two ominous signs you find in the eye: flare and posterior synechiae, excessive posterior synechiae. If you have a lot of posterior synechiae and a lot of flare, this patient is probably going to run into trouble post-operatively.
Okay. Someone was asking, do you prefer hydrophobic IOLs?
They are both biocompatible. The hydrophilic has an advantage that the cells cannot stick to it. So you have a less possibility of lens deposits. Whereas the hydrophobic, there is a thin layer of protein that sticks to the lens and makes it biocompatible. So they're both biocompatible. They're both equally good. You can go with either.
Okay. So I guess this concludes. I just wanted to stress the point that if you're going to have a patient who's going to have a cataract surgery and you're seeing this patient for the first time, do not rush to have the cataract surgery. Control the patient well enough. I always tell the patients, it's like you have money in the bank. So just don't waste it, because if you waste it, if you draw the money out too early, you're going to lose it. So just keep it and control the patient. Even if it takes 6 good months to control the patient, it's like you're saving your money in the bank. And the timing of the surgery is the most important part. And I always describe it as being we're going for a deep dive with the patient, and we all have to be ready. And we have a pre-plan of the patient is controlled, and if the patient, really reactivates after surgery, because by default, all uveitic patients, even though those controlled over several years, will develop some cells after they have the cataract surgery in uveitis. So I guess this is one of the key points that we have to stress on in the pre and post operative care of such cases.
I agree.
Okay, I guess I'll start.
Okay.
Should I start then? I just wanted to apologize on behalf of Dr. Dina. She wasn't today supposed to discuss masquerade syndrome, but she was not able to join us. However, she promised that if she can join us before we round up this meeting, then she will join in and give us her presentation. So I'm sorry about her absence with us. Okay, let me start. So today I'm going to discuss TB. Sorry, let me just start. I'm going to discuss TB uveitis, which is one of the most challenging. Sorry, something wrong here. Okay. So it's actually one of the most challenging entities in uveitis. And it was first described, ocular TB was first discovered in 300 years ago. And what we know about ocular TB now is that it accounts to 18% of TB patients, and TB patients account up to 1/3 of the world's population.
The sound is breaking up a little bit.
Oh, okay. Is it better now?
Yeah, I think so. Yeah.
Okay. So the problem with ocular TB is the actual bacilli. The bacilli is about 1 to 5 microns. The main problem with the bacilli is to remain suspended in the air for several hours, and it only takes about 5 to 200 inhaled bacilli to actually cause an infectious focus in the lungs, which spreads to the eye through hematogenous spread, or it might spread from other extrapulmonary sites, such as the intestine, to the eye also through hematogenous spread. In ocular TB patients, only 1% of them will have active pulmonary TB, and 20% of them will have active extrapulmonary TB. And what I mean by extrapulmonary TB is the GIT bone lymph nodes, which was one of the most important sites of extraocular TB, CNS or CVS, and they get to the eye through the blood. And this was described in the 80s, where they mentioned that ocular TB can occur in association with pulmonary TB or in isolation with no clinical or laboratory evidence of pulmonary infection. Ocular TB is one of the most difficult to diagnose and treat because of this fact that actually it gets to the eye through the blood into the choroid. The choroid is very vascular, and they tend to start to replicate in the sub-RPE area. And actually, they have the character of able to replicate in areas where there's very high oxygen pressure, such as the choroid, and they can survive the stress that is posed by the activation of macrophages and even low pH. And in these conditions and environment, the RNAs tend to replicate aggressively. And this is why actually ocular TB can be very aggressive and sight-threatening. The manifestations in ocular TB occur due to either a replication of the organism or hypersensitivity reaction triggered by infectious agents. I'm going to discuss it with you some cases, and I'm going to stress on the findings we find, and we're going to see how these findings, clinical findings we see, may mimic so many other uveitic entities. And likewise, we have the problem of having lack of confirmatory diagnostic tests in TB that actually make it a very difficult challenge. I'm going to use the COT study, which is the collaborative ocular tuberculosis study conducted over 10 years retrospectively. And they recruited about more than 1,200 patients. They recollected the record of these patients, and they described epidemiology and clinical features of ocular TB and also determining factors affecting treatment outcome in ocular TB. Now let's go through a few cases. Now this is a patient who comes, and this patient actually has just perivascular infiltrates along the veins in the periphery, and you can see areas of ischemia, and you can see that by the hemorrhage and the vitritis, and you can appreciate the ischemia, how aggressive and severe it is in the periphery. And we can also see active vasculitis denoted by this perivascular leakage. And this is a male patient. He had chest imaging showing old lesion in the lungs, and he had lymph nodes, enlarged lymph nodes in the lungs as well. He had a positive PPD and a quantiferon, but his acid-fast bacillus of sputum was negative. And this is a form of occlusive vasculitis that we commonly see in TB. This patient received treatment for TB with steroids and had his laser done, and we can see how the lesions, active lesions regressed. A second patient is a 42-year-old male patient with chest imaging that was free, He had positive tuberculin, positive quantiferon, acid fast, sputum was negative, and he had a family history of TB. His brother had TB. And we can see very peculiar appearance of multiple inflammatory aggregates or coughing along the vein in along the superior and inferior nasal and temporal arcades all over. And the patient received treatment and had regression of these lesions and of the inflammation as a whole. And we can see that these lesions developed into partially pigmented atrophic scars along the vessels. And this is a form of non-occlusive vasculitis that we may occasionally see in TB. Now, the point is this patient, I'm showing you up this patient also with a normal CT chest with positive quantiferon and TB. Because of the very similar lesions, this patient has occlusive vasculitis and has these very similar lesions that show staining along the vein in fluorescein. And cutting through this by OCT, you can see that this patient actually has changes on the RPE that shows why this is stained, and changes also on the underlying choroid. And this is known as Knox. It was described by Knox. And we can see this in TB patients. And this patient had oral ulcers, and he was thought to have Behçet's disease. And when he came to me, he was about to be placed on biologics. If not that, just the PPD came back positive, and they were going to place him on biologics with anti-TB medications. And to me, this is very diagnostic for tuberculosis. Another type is the thick exudative vasculitis, and this was a patient with mesenteric TB. A few interesting points about this patient. The first thing is that his ACE was 112, which is high, but because he was a smoker. So do not confuse your labs and do not rush to diagnosis. This patient doesn't have sarcoid. He's just a smoker with high ACE. But the other point is he has very thick perivascular infiltrates. Sometimes you could see this may spread to the retina and giving a form of retinitis, or sometimes in TB, these patients may have retinitis separate and away from areas of vasculitis. This is a second patient. She's a female. She had normal chest imaging. She had high tuberculin test, and quantiferon was positive. Now, this patient had cystoid edema and had fern-like leakage along the small vessels, and along with vitritis and cystoid edema. And this was after the patient received treatment for TB. We can see how the cystoid edema actually completely regressed. So in the COT study, they found vasculitis in about 40% of the cases. 45 of those were occlusive vasculitis. The exudative type, which is the type I had shown you in the mesenteric TB patient, accounted up to 28% of the cases, and the choroidal scars or the Knox signs that I mentioned were found in about 9% of the cases. Choroidal TB is sometimes one of the most aggressive types of TB because, as I mentioned, the bacilli finds its way to the eye through the choroid, which has very high oxygen tension. The choroidal TB could be in form of multifocal choroiditis, which appear as multiple rounded non-contagious lesions with distinct borders, or may come in form of MP-like lesions. This is a patient who came to me. Her sister had TB, and she had an old lung lesion of TB with positive quantiferon and tuberculin. And the question here is, if this patient came to you, are you going to treat this patient that has multiple lesions that seem quite dormant with no vitritis and no signs of anterior segment inflammation at that time? Actually, these patients can be followed up. They do not have to be treated. This patient doesn't seem to be active. You just keep an eye on the patient, and you can see through several years almost stable appearance of the fundus. Another form of TB is the formation of the choroidal tuberculoma, and this is very dangerous and difficult type of TB ocular inflammation because it's caused by a replication of the bacilli within the choroid. And if this is not controlled, it can actually form a subretinal abscess. By OCT, these lesions appear as large heterogeneous hyperreflective lesions with underlying hyporeflectivity, lobulated surface, presence of inflammatory aggregates in the inner retina, and subretinal fluid. Serpiginous type of choroiditis, as in this patient who is 56 years old, she had a positive CT chest of an old lesion with positive quantiferon and PPD. And we can see that she has the typical serpiginous multifocal lesions that usually start in the macula, but you have to watch out for the presence of these lesions in the mid-periphery. As we can see, she has a lot of lesions in the mid-periphery. Usually have moderate vitritis. This is the fluorescein of this patient. The fluorescein in these cases might not give you enough data. The only all you need to know about these types of fluorescein is that in the early frames in the active lesion, they appear as hypofluorescent, and in the late frames, they show hyperfluorescent appearance and staining at areas where the lesions have started to scar. However, autofluorescence may be more useful in these cases, and this is her first, when she first showed up. We can see she has multiple lesions in the macula and the mid-periphery, and the mid-peripheral lesions appear quite fuzzy. And this is after treatment. The patient started to receive treatment, and we can see the lesions have become more well-defined and are starting to be more hypo-autofluorescent. And the lesions that were seen temporarily actually have almost completely disappeared. The patient continues to receive treatment, and the lesions continue to be more hypo-autofluorescent, meaning that there is starting to be an RPE defect in these areas. The nasal lesions have completely resolved, and this is after 10 months of treatment. We can see the lesions have completely regressed, and the patient is ready to stop her medications. This is a patient who came to me. He's 25-year-old, old lesion in the lung with positive tuberculin and quantiferon. And this patient started with appearance that's quite similar to MP or ambiguous. And I saw this patient 3 weeks after he had this colored image. And we can see that the patient actually continued to develop into serpiginous type of choroiditis. And we can see the multiple serpiginoid lesions throughout the posterior pole and mid-periphery. And this is the autofluorescence after the patient had received treatment. This same patient had vasculitis at a point, and I will explain about this later. And you can see this completely occlusive vasculitis with intraretinal hemorrhages that were previously absent. And this is the resolution after the patient had got treated and had his laser treatment. And these are MVDs and that were seen in OCT when the patient first came, and then after the patient received treatment, and they have almost completely regressed. And sometimes in uveitis, we have what we call reactivational MVDs. This, if you have just MVDs, and you could see this sometimes in intermediate uveitis, and you do not have MVEs, and you do not have ischemia, which is quite different from the case I'm showing you. This patient may not need to have laser. This patient could have regression of just the MVDs after he receives or she receives treatment. However, if you have areas of ischemia in the retina, or you have MVEs, this is an indication of laser for this patient. Serpiginous choroiditis by imaging has been divided into active, healing, and healed. And let me elaborate for those who enjoy imaging or do imaging. Let me explain these different stages by the different imaging modalities. Now, this is an active serpiginous choroiditis, and this is of the patient I had just shown you with MVTs. During the active stage, we can see a hyperreflective deposit in the inner layer. We see loss of the outer layers that we can see all through and in the red circle. And we have loss of the choroidal details. We can almost see no choroidal details in the areas that are active compared to the areas that are not active. And we have a decrease in the choroidal reflectivity. It becomes more hyperreflective, and we have choroidal thickening, as we can see in the yellow circle and with the white arrow, as compared to the area that has no activity. By autofluorescence, these areas, like the one in the red circle, would show a stippled hyper-autofluorescent appearance, as we can see either by the white arrow or the red circle. In fast imaging, which is also seen in OCT angiography, and OCT angiography would show quite different appearance. By OCT angiography, it would show a homogeneous hyporeflective appearance. By in-fast imaging, the areas that are active would give a hyporeflective appearance, and by autofluorescence, it would give us the hyper-autofluorescent appearance. I want you to look at the yellow circle. We can see that the OCTA shows us the appearance of the edge of the active lesion, and fast shows it it's very subtle, you can't really see it. And the autofluorescence just shows a very mild area that's starting to develop, that's shown perfectly well on OCTA. And this is another area. You can see the in-fast imaging just showing us almost nothing here, while you can see the edge of the active lesion by OCT angiography. And this was described either to be actual fluvoid or due to block reflectivity from the overlying inflammatory lesions in the deep retinal layers. And here by autofluorescence, you can almost see nothing in the blue circle, while here it shows perfectly well on OCT angiography. The healing stage by autofluorescence would start to show areas of hyporeflectivity. We can see the first visit, and you can see the red circles. All these lesions are starting to show a form of hypoautofluorescent appearance, And we can see that after the patient received treatment, this patient was on treatment, the lesions continued to develop. And this is a point I'm going to explain later, how lesions may continue to progress even after you have started treatment for a while. The healing stage by OCT would show the presence of knob-like lesions in the RPE with disrupted RPE and photoreceptors and external limiting membrane. And we can see comparing the active with the healed lesion. The choroid would start to show increased choroidal reflectivity, irregular loss of the choriocapillaris. We can see here that choriocapillaris is almost lost compared to the areas that were not affected, and we have the dilated underlying choroidal vessels. By OCTA, this patient, this is the healing stage. We can see they show irregular flow void signals. This could be due to revascularization or due to the preserved underlying choroid. I believe it's due to it's starting to show the underlying choroid because choriocapillaris actually has attenuated. And we can see the comparison by OCT. The healed stage by autofluorescence would start to show more homogeneous appearance within the lesion, homogeneous hypoautofluorescent appearance. And by OCT, we can see that these patients will start to have restored appearance of the outer layers, atrophy of the overlying inner layers, and actually thinning of the choriocapillaris with the choroidal vessels. And by OCT, again, it would start to show areas of irregular areas of flow void with prominent underlying choroidal vessels. And these novel findings were described in a paper, in an article that was published in 2017. And they actually mentioned that the use of OCT can help us study and follow up patients that have serpiginous choroiditis. This is a patient, another patient that had probably ambigenous or confluent and healed serpiginous. And what's interesting and why I'm showing this case is this patient had a small focal lesion in the fellow eye. And this focal lesion is important because if we have a look at another patient that came to me, this patient got treated 2 years earlier for affection TB of the left eye. And he had a small lesion at that point, that was 2 years earlier, in the right eye. After the patient had finished his TB treatment by 2 years, he came in with severe occlusive vasculitis of the right eye. And what I'm trying to say here is that if you have a small lesion in the fellow eye, you have to keep on following up the patient. And also, if the patient has received TB treatment either for the affected eye and it reactivates in that eye that was treated, or start to develop the activity in the fellow eye that didn't have any activity, we will have to repeat the anti-TB medications all over again. And choroidal TB was found to account for 60% of the cases in the COT study, serpiginous in 46, tuberculoma in 13, multifocal choroiditis ambigenous in 9%, and MP in about 3% of the cases. I'll move on to intermediate uveitis, and intermediate uveitis could come in form of presence of vitritis with cystoid edema with areas of perivascular leakage. And this is a patient who was known to have chest TB several years back. And the patient received anti-TB medications, and we can see that the perivascular leakage resolved, as also the vitritis resolved, and the macular edema also resolved. This is another patient who had Pott's disease, and this is TB of the bones. And she had multifocal lesions in the periphery, and also she had vitreous aggregates, but she didn't have a lot of perivascular leakage or macular edema. She simply had the vitritis, along with these pigmented lesions, which we occasionally see in patients who have intermediate uveitis. So if you have a patient with intermediate uveitis, has peripheral multifocal pigmented lesions, you may consider TB in the diagnosis. In COT study, intermediate uveitis was found in 14% of the cases. Snowballs were very common in up to 32% of the cases, as compared to the presence of snowbanks. Snowbanks were only found in 10% of the cases, and cystoid edema in 22% of the cases. This is another patient with intermediate uveitis and cystoid edema with mild perivascular leakage in the mid-periphery. The patient received treatment, and over the course of treatment, the cystoid edema resolved, but developed a very tough epimacular membrane with macular traction. And what I want to say about this case is that sometimes patients who have infectious uveitis, such as TB and toxoplasma, tend to develop thick epimacular membranes, so either at the macula or in the periphery. So you have to watch out for these membranes and make sure that they're not developing traction or breaks that might progress into retinal detachment. Neurotonitis is a very interesting entity, and this is a patient with TB who came with neuroretinitis and occlusive vasculitis, and it could occur as a hypersensitivity reaction or could occur due to the spread of the organism to the optic nerve either through the choroid or through juxtapapillary retina. And this is after the patient received treatment. This is a patient who actually had occlusive vasculitis, received treatment and laser treatment, received his steroid and anti-TB treatment, and had also laser to the areas of ischemia. Why I'm placing this is that when the patient first came, this was how the fundus looked like. And after the patient received treatment by 2 weeks, we can see that there's a very large area of occlusive vasculitis that occurred despite being on treatment. This is what we call the paradoxical worsening. The paradoxical worsening could occur in form of neuroretinitis, anterior uveitis, vasculitis, or serpiginous choroiditis. And this is the patient I had shown you earlier, the patient with the montage images and whose OCTA images I showed. And actually, you can see after the patient received anti-TB medications that the lesion started to spread and increase. And this is acceptable, and we see it quite often. All you need to do is actually increase the dose of oral steroids. Sometimes some have advised that this patient could receive intraocular steroids, but I wouldn't do this in a case of infection. The cause of paradoxical worsening is multifactorial. It could occur due to increased type 4 hypersensitivity. Mainly, I believe it would occur due to increased exposure to the microbacterium antigen. As you start to treat the patient, the bacilli kind of break down. So the antigens or proteins within this bacilli start to spread or become loose within the retina. And so the eye starts to react to these proteins because they are unknown to the eye, and they tend to form what we call the paradoxical worsening. Ultra-wide field imaging was found to be quite useful in these cases because they found that 36% of the patients may be detected to develop this kind of worsening, as compared to 14% that was previously reported if you are using the regular type of imaging, not the ultra-wide field. Usually, the paradoxical worsening would occur within 2 to 6 weeks of initiation of treatment. And as I mentioned, you need to just increase the dose of oral steroids. This is a patient who came to me with scleritis, and actually this patient had TB scleritis with exudative detachment, and after the patient received treatment, we can see that the detachment resolved, and it was found in the COD study to account for 10% of the patients with that were enrolled in the study. Do not forget that flexural conjunctivitis and TB nodular episcleritis are also found to be types of ocular TB. As concerning the systemic condition, we usually expect that patients with ocular TB are either cachectic or have had cough for a long time or hemoptysis for a long time, or actually have open foci within the lungs. This is not the case. The COD study reported that 92% of them do not have any symptoms suggestive of TB. And chronic cough, which we regard to be one of the most important in review of system, was only seen in 2.5% of the cases. Hemoptysis was found in only 0.3%, which is actually less than 1% of the cases. So we cannot depend on the systemic symptoms of systemic TB to diagnose ocular TB, which makes it more of a challenge. So we have the investigations that we know. Let's start with the immunologic test, or the tests that we all know, the tuberculin skin test and quantiferon TB gold test. Actually, the quantiferon was found to be more sensitive, 93% as compared to 75%, but the specificity was quite similar in both tests, tuberculin and the quantiferon. Now, none of them is going to tell you which if this patient has active or latent TB, if they came back positive. But if the quantiferon came back positive, you're sure that this is not due to the BCG vaccine. It's either due to the patient has latent TB. The patient, it confirms that the patient has been exposed to TB. The fact that it's latent or active cannot be confirmed by this test. In the COD study, they found that the positive TB skin test was 85%, and the quantiferon TB gold test was 88%. And previously in literature, they found that the quantiferon is just slightly superior to the tuberculin skin test, and they advised that we should use both of them hand in hand to help us interpret our results and try to get to a diagnosis. The tuberculin skin test has to be done by people who are trained to do it, because we have a problem with tuberculin skin test, how it's done, and it's read in Egypt. We need to know the size of the induration, which is the diameter of the induration. Some use the vertical and horizontal, and some use just the horizontal diameter. We know that if a patient has it less than 5 millimeters, it's negative, and if it's above 15, definitely it's positive. But we have this gray zone where the induration is between these two figures. So if it's between 5 to 10 and the patient is immunocompromised or comes in close contact with TB patients, or even has a healed TB lesion on chest imaging, regardless if it's chest X-ray or it's CT. So a healed TB lesion for us ophthalmologists is a very important finding in chest imaging. It might not be important to the chest doctor, but for us to diagnose, it's important. However, if it's more than 10 millimeters, and the patient is in an endemic area, like here in Egypt, or is a health care worker, or has been in a long-term facility, this patient would be regarded as having a positive PPT. As for CT chest and chest X-ray, the COT study found that the chest X-ray was the CT chest was more useful. It showed 23% of the patients had changes by chest X-ray. However, by CT chest, 65% of the patients enrolled had changes. So the CT chest for me is more important. I would always recommend it. I would ask for a high resolution without contrast. You don't have to use contrast for these cases. And either having a healed lesion or active TB lesion for me is quite significant. So how would we diagnose a patient with ocular TB? According to the COT study, they said if a patient had both criteria 1 and 2, and what's 1 and what's 2? One is the patient has clinical signs suggestive of TB, which are the signs I mentioned with the cases I showed you earlier, and exclusion of other possible causes of uveitis, plus at least one criteria of 3 and 4. What's 3 and 4? The patient we are able to isolate the mycobacteria, meaning that the patient had an acid-fast bacillus sputum test that came back positive, or the patient had a cold abscess that had pus and was cultured, or we were able to have a PCR test, which is not commonly used in practice, and we were able to actually isolate the organism through this PCR, either from the eye or elsewhere in the body. Or, which is, I guess, what we use more commonly, number 4, which is having the tests, having a positive tuberculin, quantiferon, or having positive signs in chest imaging, either in form of healed or active lesion. So 1 plus 2 with 3 or 4 would make us think of or more towards a diagnosis of ocular TB. The treatment that has been agreed upon both by the World Health and the CDC is the 4-drug regimen, which should be taken under the care of the chest specialist, which is isoniazid, ethambutol, rifampicin, and pyrazinamide, along with oral steroids and pyridoxine. Now, the ethambutol and pyrazinamide are going to be stopped after 2 months, while the isoniazid and rifampicin will be continued for 6 to 9 months and occasionally up to a year. But when you're having these medications, you have to make sure that you're checking the patient's liver functions, kidney functions, and CBC. And if the patient has started treatment and comes back to you in 3 weeks or a month and is very eager because he's not getting any improvement, or maybe he's starting to worsen a bit, you have to reassure the patient because it takes about 6 weeks before the medication starts to show some effects. The COT study found that 87% of their patients had successful treatment, and treatment also decreased the risk of recurrence. They found that those patients who are at high risk of recurrence are those who had choroidal involvement, vitreous haze, and snowballs, while those who had ambiguous or serpeginoid type tend to have better outcome. Thank you.
Thank you very much, Dr. Trace. Very, very nice presentation, very illustrated. There has been a couple of questions from the audience. One of them is a doctor who had an experience with a patient that was treated for 13 months, who had anterior uveitis and proven TB with a 23 millimeter skin test. And the patient improved on treatment. And whenever
he had anterior uveitis, I'm sorry? Anterior?
Just anterior uveitis, but positive tuberculin test.
Perfect.
And the patient improved on anti-tuberculosis treatment. Once she stopped the treatment, after 13 months, she'd have a recurrence. So you've answered that already by saying that you repeat the treatment. The add-up question is, do you, even if it's an anterior uveitis, do you give systemic steroid as well, right? You don't give anterior.
But actually, the COT study, they actually revealed some of the results concerning anterior uveitis, and they mentioned that if the patient only had anterior uveitis, they didn't find that the anti-tuberculous treatment was going to be very useful. But there was disagreement in the consensus that if the patient was having recurrent anterior uveitis or granulomatous, that probably they would place this patient anti-TB medications. And so many other studies apart from the COT studies, true literature, have also shown that using anti-TB medications in anterior uveitis was useful. So I guess you just have to balance what you want from your patient. I mean, if this patient is just having anterior uveitis that can be controlled by topical steroids of low dose, and this patient is not having granulomatous uveitis, then maybe you would prefer to keep your patient on steroids, just topical steroids, because we're talking of anterior, right? So long as it's really anterior, we don't have intermediate uveitis, so we don't have vasculitis. Maybe topical steroids can help instead of exposing the patient over and over and over to anti-TB. So it depends on what kind of reactivation is he having in his patients.
The other question that she had was about PCR, but you already answered, and I've answered it already, that PCR is not very useful because it would detect only direct invasion to the eye rather than hypersensitivity to the protein, to the...
the point about PCR is that PCR is taken from the vitreous fluid, and actually the bacilli are under the RPE. So the PCR can actually miss the bacilli. So even the COT study found out that using PCR is not really going to help us in diagnosing these cases because we have a lot of false negatives. That's why they didn't recommend the use of PCR to diagnose.
There's another question I didn't understand very well, but I think they were asking whether you give recover steroids with anti-tuberculosis treatment. You already answered that.
Yes, I do.
It's a must. You have to give.
It's a must.
And sorry.
I have had a few cases actually that go to the chest hospital and they receive the anti-TB medications. They've come back to me in 3 months without coming back for me to start the oral steroids or missing the fact that I told them to come back. And actually, I have seen some of them to have improved quite well, even without oral steroids. But what I would use generally is I would use oral steroids definitely with the anti-TB medications. It decreases the incidence of the paradoxical worsening. It helps the vasculitis, helps the vitritis, helps the macular edema. So I guess, yes, I would do this definitely.
There's another question, whether if this patient is resistant to anti-tuberculosis treatment, whether gene expression can, an aqueous sample with gene expression from the aqueous. I'm not familiar actually with I thought she meant PCR. But we've already mentioned the PCR. The yield of PCR is very, very low with a very high chance of contamination. So it's not very useful. The other question is if you get a flare-up after treatment, which you usually get,
we will go back.
How can you differentiate whether this patient requires more treatment, whether the treatment is successful or not? I guess you wait for a longer time to determine, at least 6 weeks, you said.
Yes, 6 to 8 weeks. We don't definitely don't, we're not going to stop treatment for 6 to 8 weeks.
Okay. And the steroid dose it tends to be a large dose, 1 milligram per kg or so.
Well, actually, usually I would not go very aggressive with steroids. I usually use 40 milligrams. In literature, others have mentioned the use of very high doses. Usually I'd be more cautious with these patients.
Okay. Very nice. Okay. Thank you very much.
Okay.
So I think we move to the next presentation. And if anyone has another question, if you can check it, Dr. Trace.
Okay.
Check the questions. Just a second. Hi. So our next presentation, I'm going to talk about the relation between uveitis and intraocular pressure. Uveitis can cause either, can cause ocular hypertension or can cause hypotony. In the presence of hypertension, this can occur in context of an open angle or closed angle. In open angle, it can be trabeculitis, angle debris blocking the trabeculum, or steroid-induced. Closed angle, it can be because of a oppositional narrow angle, peripheral anterior side or peripheral anterior synovium. Hypotony, it can be due to ciliary body atrophy or ciliary body detachment. Now we're going to discuss each of these entities. First of all, ocular hypertension, open angle. The first item is hypertensive uveitis or trabeculitis. This is a relatively new name given to viral uveitis in general, in which often there is an increased intraocular pressure secondary to trabeculitis, associated trabeculitis. Herpes simplex, herpes zoster, CMV, and rubella have been isolated by PCR techniques. Diseases that previously we didn't know the cause of like post-Schlossman syndrome has been often associated with CMV virus. Fuchs has been associated with rubella, depending on from the place where the patient came from. Many of the what called idiopathic anterior uveitis turned out to about 20% or so turned out to be herpes simplex or herpes zoster. Here the treatment is anti-glaucoma, including prostaglandin analogs, steroids, and oral antivirals, which is better than topical antivirals. Sometimes revert to topical, which has a it's less effective but has less side effects if you're going to go for a long period of time on treatment. This is a slit lamp showing very little signs, very single KP in post-Schlossman syndrome. Here's another example of KPs distributed in all over the cornea, especially in the central edematous area. This is again characteristic. Skin lesions in herpes zoster can be suggestive. The presence of sectorial or patchy iris atrophy again is suggestive of viral uveitis. The second item in open angle is debris in the angle. That can be cells, fibrin, or direct infiltration. To the left is granulomatous uveitis associated with increased intraocular pressure. On the right, there is an actual direct infiltration with a granuloma to the inferior angle. The second category is closed angle, the ocular hypertension in the presence of closed angle. Here, the first type is secondary to pupillary block. Because of posterior synechia, if it becomes 360 degrees, this would prevent the flow of the aqueous and would cause a forward bowing of the iris, causing an iris Bombay with closure of the angle that can occur pretty acutely in an emergency way. Here, the treatment is in emergency with anti-glaucoma, including oral Diamox or Sidamex, steroids, iridotomy or iridectomy. Iridotomy is probably inferior because it tends to close again. If you do it with YAG, it tends to close again. And surgical iridectomy is probably better. Here is a slit lamp appearance of Bombay iris with a very shallow angle, narrow angle. Here is UBM before and after YAG. You can see the angle was closed and opened up after the YAG. The second item is a secondary ciliary body swelling. And this is because of the ciliary body swelling with a forward displacement of the iris lens diaphragm causing narrowing of the angle with shallowing of the anterior chamber. Actually, this item is only described in Harada, and the treatment here is with steroids rather than anti-glaucoma. This is a very shallow anterior chamber, as you can see, and this is a patient I've presented before, a 15-year-old child with Harada who had the primary presentation of acute angle closure glaucoma bilaterally, and that she only improved when given immunosuppression. Here is her B scan before and after the Harada became active with diffuse choroidal thickening and inferior serous detachment. The third item in closed angle is a closed angle secondary to peripheral anterior synechia, and this would behave as a primary open angle glaucoma or primary angle closure glaucoma. Here the pressure is chronically high, and you can find signs of inflammation of cells and flare in anterior synechia. The peripheral anterior synechia can be seen by slit lamp, gonio, or UVM. Here the treatment is medical mainly, and if it's not controllable on drops, then it's you have to do a trabeculectomy after the 3 to 6 month period of no inflammation, and sometimes you would go for a valve implant, especially in children. Here is UVM appearance of a peripheral anterior synechia closing up the angle, and here is the synechiolisis by viscoelastic needle. On the other side, on the other hand, the patient can develop hypotony. Patients with uveitis can develop hypotony. It can be either due to ciliary body atrophy from repeated inflammation, or ciliary body detachment, either in a form of inflammatory effusion or adhesions. Here is a subciliary cleft, iris atrophy with loss of the normal appearance of the processes. And here is a photograph, I got that from the net, with membranes over the ciliary body. Here are a couple of patients. The first one is a 40-year-old lady who came with chronic uveitis, idiopathic, probably parsplanitis, with a vision of only counting fingers, 2 meters in the right and 60 centimeters in the left. Anterior chamber, there's just a little bit of flare. Bilateral posterior synechia, very difficult to see fundus because of the small pupil. However, a BIO score of +3 bilaterally. Disc was swollen. Here is her B scan with diffusely thickened choroid and an elevated disc. OCT showed a markedly wrinkled RPE. So this patient has had a hypotony, bilateral hypotony. It's not understood why. I tried to do, I asked for UVM, she refused. I gave her orbital floor steroid as a trial, but did nothing. I consulted with a vitreoretinal surgeon for vitrectomy and silicone oil, but he said that the results are usually very poor and decline from doing anything. This is another child with the juvenile idiopathic arthritis who was doing very well actually after cataract removal. However, the parents stopped the treatment after the patient. They felt the patient is good, so they stopped all treatment, including her Humira, and she developed a very severe relapse. After controlling the relapse, she started to develop hypotony. And it's a progressive hypotony.
Voice isn't clear.
Can you hear me?
Your voice is breaking.
Breaking, okay. Is that better?
Not really.
Okay. I'll try with Is that better?
No.
Is that okay now?
No, it's worse. Don't use the earpiece. Okay.
It's probably the internet, so I can't do anything about it.
breaking.
So this is an elevated disc, as you can see, with markedly thickened choroid. I did a UBM, which showed just a thickened ciliary body with no processes on it. Vitreous prolapsed. When I did a better resolution UBM, it revealed a remnants of their capsular bag stretching over and pulling over the ciliary body with a very shallow cleft. That can explain her hypotony. So what's the management of hypotony? There is medical treatment, course control of inflammation with topical or topical steroids, but it will only work in steroid responders. Ibuprofen, it's not present in Egypt, so it's not very effective actually. Intravitreal steroids have been tried with little, again, success. Surgical management, in case of clefts, they try to close the clefts with cryo, argon, diathermy, and ciliary body sutures. In presence of membranes, do a vitrectomy with careful removal of membranes, peeling of membranes. In case of ciliary body atrophy, the only solution is vitrectomy with silicone oil or repeated injection of Helon in the anterior chamber or vitreous. Thank you. Are you still with me? Hello?
The voice is breaking. Thank you.
Okay. So I'm finished anyway. Dr. Atreides, are you still with me?
Problem with the voice.
I'm not sure what to do with it. So
yeah, I know.
It's the problem with internet. So
I can hear you.
Can you hear me now?
It's breaking. I can barely hear you.
Okay. So do you have any questions?
Okay. So actually, we don't have any questions. I wanted to ask you, would you, in uveitis, would you use the traditional subscleral trabeculectomy, or would you rather have an implant, like an Ahmed valve or an expression, or which would you prefer in the case of uveitis?
I would do a regular trabeculectomy, assisted trab with mitomycin, unless the patient has a recurrence. Then I would go with an implant. Or in children, I would go in the first instance with an Ahmed valve.
Let me repeat your answer. Did you say you would rather go for a trabeculectomy?
I would go with the trabeculectomy and mitomycin.
Okay.
In adults, but in children, I would go with an Ahmed valve.
Okay.
I think the internet is pretty poor, so
I guess
oh, I can't hear you. Okay. Have you muted yourself?
I do not have any more questions at this point.
Right. Okay. So I think that's the end of our course. I hope everyone has benefited from it. Thank you again.
If people are asking when you record the webinar, how are you going to broadcast it?
I'm going to put it on the YouTube, but I don't have the link yet. So I'll try to send all the participants on their email with the 3 recorded YouTube videos.
Okay.
Okay?
Thank you.
Thanks. Thank you, Dr. Atreides.
Thank you, Dr. Mohammed, so much for this webinar. Again, I'm apologizing on behalf of Dr. Dina for not being with us today. Thank you. Have a nice evening, everyone.
You too. Thank you.